Well, thank you all for having me here today. Thank you for your support of the palliative care program in the past and for considering our program again for the coming year. I don't really know how you make decisions between so many great programs, but thanks for letting me be here today to talk with you a little bit about our palliative care program. As you know, the Morton Plant Meese Palliative Care Program is here to provide care for people in our hospital setting alongside oftentimes curative treatment. We provide high quality, compassionate care to patients with advanced or chronic illnesses, life-limiting illnesses, and as well as providing care to the patients, maybe more importantly, or certainly as importantly, we provide care to the families and the caregivers of those patients who are with them at the bedside. Our goal is to reduce suffering, to manage symptoms, and to improve the quality of life of the patients we serve. So what is palliative care? Well, palliative care is, as I mentioned, it's supportive care. It can be done with patients of any age. It can be done with patients at any stage of illness. It could be advanced, life-threatening illness. It could be terminal illness, but it's not necessarily. The reason I mention that is because a lot of times when people hear palliative care, one, they are not familiar with the term at all, or B, they think of hospice care. And hospice care is end-of-life care with a life expectancy of 6 months or less to live. No one has a crystal ball, but that's the rule of thumb to admit a patient to hospice, which also provides comfort care and improved quality of life and support for families. The beautiful thing about palliative care is that we come alongside the patients and the families well before a patient may reach that point where they're eligible or they need a hospice care. So we can be there throughout the duration of a chronic illness. We can come alongside patients and help with symptom management and psychosocial support while they're having curative care. For example, a patient who has cancer is still undergoing chemotherapy, but their symptoms are out of control. They need some help. They don't know what, their family is at their wits' end. They don't know what to do. We come alongside them as palliative care and help them through this process. We coordinate pain and symptom control. We do a wonderful job of caring for the spiritual and the emotional and the mental health needs of these patients and families. Any of you may have experienced a loved one with a serious illness or a life-threatening illness, and you know how stressful that is on those of us who are the caregivers, and we're there for them. We provide family support. We assist with decision-making and transition between care settings, and we coordinate care with the primary care physician or the attending physician. So all of these things are done alongside everything else that may be happening with a patient while they're in our facility. We provide expert treatment of pain and symptom management. We provide respite from the anxiety. We coordinate care. Some of these things I've already said. We empower families and patients to have a voice in their care. Our main concern is, what does this patient want? What is this patient's goal of care? What are this family's goals of care? And we're able to come alongside, sit down. Our palliative care physician sits down with the family and spends 30 minutes with them. And we all know that is not the norm as far as physician time with patients in the hospital. As a palliative care team, we're able to do this. So we provide that ongoing support. We also support the physician's role. We assist the care team treating the patient because we add an extra layer of support that is so often needed. And we assist in discussing available options for care. Oftentimes, one of the things that I'll mention about that is one of the things that we often talk with families about and patients is, if you were unable to make a decision for yourself, what would you want? What would you want us to know about your care? So we assist with advanced care planning. We assist with making sure the patient's wishes are honored. Not to say we don't do that along in everything we do, but with palliative care, we're able to come there and really do this well. Some of the feedback we get from our patients and our families is really remarkable. One of the most common themes we hear is, I wish we had had this service sooner. I wish you had been able to come alongside with us 2 weeks ago before we got to this point now, and you could have helped us. Thank you for helping us make these decisions. Thank you for helping us understand what other things are out there. We didn't have any idea. So palliative care is a beautiful service that we're able to offer here at Morton Plant Mease. And it helps patients to get the right care. And that's the most important thing about this. It helps patients and families get the right care at the right time in the best possible way. And without funding for programs like this, we would not have them, because this is not a revenue-producing program. But it does provide wonderful care, and it does, in the long run, save hospitals money, because we help get the care the patient wants when they want it. So I thank you so much for allowing me to be here today, for considering palliative care as one of your programs. I'm a huge advocate for palliative care, and if any of you have any further questions about that, I know we don't have time today for questions. I don't know, do we? We do. Okay, we do have. So do you have any questions or comments or that you'd like to ask? Clarification? Yes, ma'am.
Does that mean that when they come in with this care, that the patient is going to pass away soon?
Does that mean that if they if they have palliative care, does that mean they're going to pass away soon? No, it does not. Palliative care commonly can be done anywhere along the continuum of a serious illness. Our goal would be to get patients well before they become terminally ill. You may have for example, you may have an illness such as a chronic illness such as COPD or congestive heart failure, and people live for years with these diseases, but oftentimes they live with unmanaged symptoms, and our goal is to help get them to a place where the symptoms are managed so that they can have better quality of life. Because if they're in less pain and less distress, they're going to be more comfortable. They're probably going to live longer. So no, it does not have to be a terminal or an end-of-life patient.
Because when people say hospice, right away they think...
With hospice, yeah. With hospice, you would have a prognosis of 6 months or less. With palliative care, not so. It could be, but doesn't necessarily mean that. Did that answer your question?
Yes.
Okay. Yes, another question right here? Yes.
My question is this something that you have to request when you come in? And is it, question number 2, is this also for children?
Great question. One, is it something you have to request when you come in? And number 2, is it for children? Palliative care requires a physician order. So if you have a family member and you feel that they would benefit from palliative care, ask your physician to write an order. So we have to have that physician order. So we work with the attending. Once we have that order, we come in alongside. And we get orders for the psychosocial spiritual piece, where maybe the physician, maybe the physical symptoms are in check, but the emotional, spiritual, mental issues are just crazy right now, and they need that help. The second piece was regarding children. In our system right now, we do not provide palliative care for children. At the Children's Hospital, the Baycare Children's Hospital at St. Joseph, we do have a children's palliative care program. Another question, right in the back.
Yes. How is this handled by insurance companies? If the person does get palliative care, is it billed to their insurance, or how does the payment?
The question was about payment. Palliative care, there is a reimbursement for palliative care, and so if your insurance or Medicare covers palliative care, then they would be billed if you had the service while you're in the hospital. However, it does not cover the cost of care. The amount of billing, just to give you an idea, covers about maybe 50% of the physician service, none of the spiritual care, none of the counselor position, none of the administrative. So it's not a money-making situation, but there are some Medicare and some insurance companies are covering, and I think you're going to see that increase as our population ages. The benefits of palliative care are really being touted across the countries. You're going to really see palliative care move to the forefront of health care in the future. Thank you. Great question. Anybody else? Yes, ma'am.
How are the patients going to find this? I know you answered that question there. I was thinking, do you have anything on the bedside tables for the families to know this, that it's available?
That is a great question. How do the patients know about this? We actually are in the process of finishing up a brochure. We had a brochure a few years ago, and it kind of became outdated. So one of our goals for this year with our grant funding was to create a brochure so that we could give it to the patients and the families. Right now, that's probably one of the weak points of the whole program. Because you have to have a physician consult, we focus a lot on physician education and nursing education. But families can't ask for this service. And, part of the thing is a patient may be really a great candidate for palliative care based on our criteria. And, and oftentimes a physician may not think, oh, this would be a great candidate for palliative care until we ask them. So, great questions. Thank you. Thank you very much.
Thanks, Eric. Hi, everybody. Thank you for having me back. We don't have any slides, do we?
We do not.
Oh, goody. Okay.
Just
Hi, everybody. As Eric said, I was with you last year, and I'll say hello again. And I'm happy to report that our Pathways program, which is a program of coaching and navigating for people who suffer from serious mental illness and substance use issues. Since we last met, this program has launched. This program has been active now for 8 weeks. This program is coaching north of 20 families and will start the emergency room and inpatient portion of the program, which I'll describe for you shortly. But we made 2 promises with this program. One, we would bring a coaching and navigation function that doesn't exist for people who suffer from this illness. You'll hear coaching and navigating for other kinds of illnesses in the health system, for cancer, for cardiac, for neurological impairment. But the one patient group that suffers more than anyone, in my mind, is people who suffer from chronic mental illness and substance use. So the first thing we wanted to do is to bring a coaching and navigation function to those patients. The second thing we promised we would do is to get to phase 2. And phase 2 is to identify the gaps and the holes that exist in the treatment system in the greater Tampa area. What are we missing? What's not available? And the good and the bad is that we've been at it for 8 weeks now plus, and there is a theme that's emerging in our environment here that we've sort of grappled with, and it's very fascinating, and I'm going to share it with you. The families who have reached out to us so far are suffering from adult children who can't seem to kick the habit of prescription and illicit drug use. They're male. They're 24 to 35 on average. And in each one of these cases, we have a situation of misdiagnosis and the issue not being a substance abuse problem. They're self-medicating themselves over some other issue of trauma that happened in adolescence. So now we have these young adults who were put together enough to hold a job, to be out there, and the first indication that there's a problem as an adult is that they lose their job. And we work with these families, we work with these young adults, and we find out that this is not about substance abuse at all. It's about a self-medication over some issue that happened in their young adolescence. So we do a reevaluation, we get them evaluated, we get them into therapy, and over time we've begun to see the drug issues take a back seat. What does that mean? That means we have a lot of educating to do with our families. When we talk to the parents of these young men, what we find, we didn't think it was all that serious. They were experimenting like other kids do. I experimented when I was a child. Why is it that these kids can't shake it? What's the problem? Well, the problem is the drugs are tougher. We have far more prescription drug problems. And over time, the society has told them to push it back, push it back, push it back. So how do we educate our families to take these issues seriously when they're 12 and 13 and 14 and experimenting with these very dangerous drugs? So that, after 8+ weeks, is the first theme we're seeing. It's very disturbing. And these young men are reporting trauma. They're not able to create good relationships. They lose their jobs. Their lives are destroyed. And their families, after all these years, have given up on them. So we feel the Pathways program has allowed us to right a lot of wrong so far. So we're at it. We're open. We're located in Harbor Oaks, right here in the back of Morton Plant Hospital. We have physicians on board, clinicians on board, navigators and coaches. Starting next week, there'll be a coach in each one of our hospitals on our inpatient units, picking up what we describe as potential treatment failures. People whose first step into treatment fails, and we've got to bring them into the coaching realm and get them going in the right direction. So the Pathways program has given us a lot of pause and a lot of hope. Each case is different, but there are some threads of commonality. We've got to make our families stronger. We have to make these issues out in the open. We've got to open it wide. We have to make sure people pay attention to this early on. If you do get someone early on and they attend to the treatment recommendations, they do get better. They do. It's when they don't engage and we don't have the right diagnosis that we fail. So we have a little work to do, but the families we've worked with so far, it's very heartwarming to see an aha moment happen and getting people going in the right direction and create a lifeline for them. So it's with great privilege that I thank you for what you've done for us so far, and thank you for what you're about to do for us going forward. But I promise you that we'll bring you back all of the great moments and all of the great successes that we'll have going forward. It's been my privilege. So please, any questions about what we're trying to do and how we're doing it, I'm happy. Questions? Yes.
If you are not allowed to come back for more money next year,
Yeah.
can we ask you to come back and give us an update?
Absolutely. It's my great pleasure. One of the things that we built in on the beginning of this program were analytics. We're keeping very strict analytics. What's happening? What are we finding? And as I said, the first thing we're finding is this theme. I don't have to wait 2 years to get a theme. I got it. It didn't take me long. On the treatment side, if I can just go past Pathways a little bit, we've been diving and doing analytics on our patient population. As you know, Baycare has a tremendous amount of the behavioral health programs that exist in the greater Tampa area. And we're picking up a very disturbing theme in our adolescents. Adolescent girls, 12, 13, and 14, severely depressed and experimenting with some very risky suicide behavior. The reason for that is our young girls in general, relate to the external world in different ways than boys do. The outside world has a tremendous impact on them. With the social media that's going on, the bullying and the tormenting that's happening, you heard about the 12-year-old who killed herself. That is very, very active in our community right now. So we're working on the bullying end, on the treatment end, and getting into our schools and tightening up our schools. But on our Pathways end, we're dealing with those other sequelae. So we've got our hands on both ends of the spectrum, so let's see if we can lift this, and I will be happy to come back and give you updates on all of that. Yes, be happy to. Yes?
Gail, how is the program being marketed in the community?
It's not. Our families, our Baycare families, they walk in the door. They're walking into our emergency room, and we're identifying them right there on our inpatient units. Right now, our services, we're 70% of the market. These families are already coming to us. So right now, the marketing for this program is internal to our families. They're walking into our emergency room. If they've come twice in the last 6 months, obviously something didn't stick. Let's get a coach. Our inpatient units, if they return. In our outpatient areas, if they occupy 3 or more of the services in outpatient, they need a coach. So we're wrapping these services as far upstream as we possibly can get to fix it. If I put a billboard out there, I would drown. I mean, the amount of behavioral health issues in the greater area are so big. So right now, we're helping the families that are already connected with us, and we're going to be overwhelmed shortly. But the more we grind on, the more we can get upstream and attend to the problem and the issue and move on. We're not a research group who has to wait, years before they come to a conclusion. We just move on the conclusion. So that's how we're doing it. Yeah.
Yeah, the preponderance of cases that I'm aware of in the child welfare system are related to moms who are prescription
Yep.
users.
Absolutely.
So I'm curious about the strain that you're seeing related to young men
Mhm.
and why you think that is. I'm suspicious that it has to do with the fact that so many women in the child welfare system are indigent. I'd be curious about that.
No, it's different. The moms in the welfare system who give birth to babies born addicted to prescription drug is one cohort. Then you've got the adolescent cohort where you can see that the girls are taking the forefront. In the end, the 24 to 35-year-olds, is it because the families are saying, the boys will grow out of it. They just, they're experimenting like I did. I had a family say to me the other day, I experimented and I got out of it. How come they couldn't? Well, because it was never about addiction. So these cohorts affect every avenue of our life. But I'm glad you brought that up. One thing that we did do this year was to get a grant from the state to put navigators in our NICUs to make sure that these moms and these babies can get to the right program. There are some pretty good programs in the area for moms and babies, so to make sure that they're connected. But it's an overwhelming number. Yes?
When the navigators recommend treatments,
Yep.
are families able to pay for the treatments, or is there a method to help them pay for the follow-up treatment?
Part of the process is to make sure that there is payment. Pathways does not pay for treatment, but there are treatment pathways for every socioeconomic group, even the uninsured. So we hook them up and we make sure they stick. The problem we have is that people say they want to engage in treatment and then bail, and then it just doesn't stick. Yes?
Yes, you used the word coach, because you spoke to a group
Yep.
a couple of weeks ago.
Mhm.
And I learned at that meeting and program what
Mhm.
the coach
Mhm.
role was. Would you explain to these ladies
Yes.
the role of the coaches?
Yes, let's use coach and navigator. Two totally different job descriptions. Coach, getting people to understand why treatment is important. Hang with them, give them the resources, give them a call. You can call it a nag if you want, but it's a coach. Once they agree to treatment, they hand off to the navigator, and the navigator sets them on their path. Okay? So if it's detox, we get them into detox. After detox, we go to rehab. After rehab, we go to quarterway house. After quarterway house, we get them a job. So coaching, which is in behavioral health, one of our biggest problems. People don't necessarily want treatment, right? You got to get them to agree that treatment's going to be helpful to them, and then you hand it off to the navigator, and the navigator gets them through the system, and then hangs with them. Now, if they get in trouble again, they call the coach. So that whole system is wired together. Go ahead.
We've talked a lot about the younger sector. Is pathways available for all ages?
All ages. All ages. The hardest age, quite frankly, to crack is the elderly. I mean, it's the hardest.
A couple points I just
Yeah.
want to make too is that the $3 million in funding, $2 million for the Banks family and $1 million from the Community Challenge, will be part of a 2-year pilot program at the hospitals of Morton Plant Use. So I want to make sure that you understand that. We hope that after the 2-year pilot program, and they're able to gather the data and the information, that it does go Baycare-wide throughout our other hospitals. So we are really in a very interesting and which we love, new innovative programs that the hospital might not otherwise be able to launch. So
Well, the other sequelae of this, the other outcome is that Mr. Mason, who is our system president, was sharing this idea with a community agency. And this community agency grabbed onto a notion of, and they're calling it Family Strong. And I started like, that's exactly what we need. We need to make our families strong so they can help the people who are sick and get better. So I'm hoping to see, hopefully in the next 6 months, an initiative, Families Strong. That's what we need for our young kids and our elderly whose families become overwhelmed with taking care of their loved ones. So there is a theme that's catching on that we hope we can be at the forefront, and you have all helped us take that spot in the greater Tampa area, and it's
we're
terrific.
$400,000 away from that second million match, so we're really close. And Kate, to your point, we hope that when she comes back next year to give us an update, we'll have met that match and secured that last $400,000 that we need for the program. So thank you.
Thank you.
Thank you. Hello, everyone. I'm Ellie Farrow. This is Deja Rutledge. We are both. A little closer. Can you hear me now? Okay. It's on, right? It is on. Okay. I'm Ellie Farrow, and this is Deja Rutledge. We're from Social Services and Case Management at Morton Plant Hospital. We do oversee the social workers that are in our department, do the discharge planning piece. One of the things we focused on is the Indigent program. And some of the main purposes is to help patients when they're going to be discharged, and we know that they're going to have medications, to help them access programs that they're eligible for, whether it's Pinellas County Social Services, some of the pharmaceutical companies, those types of things. Our main purpose is to reduce the admissions, patients coming back into the health system, coming to the emergency room, and also the non-compliancy. With a lot of the people with the indigent population, the economy is stressful, so they don't have the funds to be able to get their prescriptions filled, so we try to fix that gap a little bit to prevent them from having to come back in. Basically, the way the program works is the patients are identified either from the doctor, the nurse, the social services, or the family member, the patient themselves. They let us know, the social workers know what their issues are, what's going on in their lives. We're able to figure out if they're eligible for any type of assistance. Then we're able to give them a Medicare a prescription filled for a 10-day supply. That 10-day supply is to get them to the next step, whether it's the free clinic, the county social services, the next step to get them connected to getting their prescriptions filled. We work with the Mies Countryside Pharmacy, the Morton Plant Pharmacy, and also the Walmart. But the patient's able to go directly over there, pick up their medications, and not have to pay for that. That's the main purpose for this grant here. The part with the transportation, when we have patients that are needing to get home, we try to get them the caravan, which is the volunteer services. If they're not available or we're not able to get into their slot schedule, we're able to use the bus passes if they're appropriate, or we get them a taxi home. So we try to work on those ways. Occasionally we'll also need to do wheelchair transport or an ambulance. Again, that's to be able to get them discharged that same day that the doctor's ready for having them to be discharged, to get them connected there. Some of the benefits to the health system is it saves the hospital days by not reducing our length of stay, decreases the return to the emergency rooms due to the illness or the repeated illness, decreases the hospital admissions as a result of the inadequate outpatient treatment. There's no overhead expenses because the social workers are the ones that are actually seeing the patients and figuring out what their needs are and making those referrals. Benefits to the community and the patients. The patient will be able to have a start of ongoing treatment, meaning getting them their medications to get started, to get to that next level, to get the rest of their prescriptions filled, especially if it's ongoing need for medications. We give them a connection of the knowledge and the resources of where they need to go and what they need to bring. Some feedback from our patients. One thing I think it really helps the patients, gives them that ease of knowing that they have the medications they need to be discharged, that they're not going to get sick again, their infection's not going to come back again, that they're able to follow through, finish their antibiotics, and they know the doctors that they're following up with for their follow-up care there. Oops. Just some savings. We put some stats together. Today, as of from January to October, we have served 593 patients, billed over $58,000. We saved 343 hospital days, prevented 257 admissions, 297 ER visits. We saved approximately $300,000 in unnecessary hospitalizations by discharging the patients directly from the emergency rooms. A lot of times patients will come to the emergency rooms because they weren't able to get their prescription filled, maybe from their doctor's office or from another emergency room. So they come to one of our emergency rooms. So we figure out what do you need, get that prescription filled, and then they're able to leave and not have to be admitted into the hospital. And many times it could just be that antibiotics that they need to get taken care of, but when they don't follow through and get that antibiotic, their infection gets worse, and then it becomes IV antibiotics instead of just pill form. So even that cost can double there. So we try to catch that before it gets very costly. Totals approximately $840,000 in cost savings to the health system. Our financial aid counselor in our department put some of these stats together. But thank you from the case management team. Does anybody have any questions for us? Uh-huh.
I'm sure you probably coordinate with stores or outlets and so forth that offer free antibiotics and free blood pressure medication. Like
Yes.
Publix?
Yep. The places that provide the free medications, or even the $4 ones, we do definitely connect with them and find out which place is the closest where that patient lives and have them stop there and get their free medications. Yeah, we do that. And the ones that are on the $4 list, we also try to talk to the physicians to find out, are any on this list are just as effective, and the doctors are very good working with us on changing the medication types also. Good point. Any other questions? Deja, did you want anything? No. Thank you very much for having us come today.
And good morning. And it is again a pleasure. I have spoken with you under our gestational diabetes grant that we started in 2007, and several of your faces are very familiar to me, and I appreciate your support over the years. I am a certified diabetes educator and have been working in our center in the outpatient education services for 13 years and 16 years with Morton Plant Meese. I am also a registered nurse, and I also have, like many of us, have different hats we have to wear. I'm also the program coordinator who works on the curriculum and meets the standards of accreditation that our center must hold to be recognized by pay sources such as Medicare and other private payers. I started out getting more involved about 5 years ago when I took on my role as program coordinator. I'm looked upon as a clinical lead, and my role as a program coordinator in a diabetes education center is to recognize the needs within the community and seek the support the community needs. We started coming at you in 2007 with our gestational diabetes grant because what that covered for us was all women, regardless of their income, if they were uninsured, self-pay, or had insurances to cover the pregnancy health care, but not the education component when they were discovered to have gestational diabetes. Those monies covered their care for education services, and we have registered dietitians and registered nurses on our team, all of whom are certified diabetes educators. And through that support, we have now gained and continue to have every year since 2007, I would say probably just about every referring possibility in our obstetrical groups and within this community. And it's growing out into Tampa, Oldsmar, West Chase area. They're coming into Morton Plant Mease services and Baycare healthcare services. And so we've grown, and we've grown to Pasco County and through North Bay Hospital. We are now servicing the full 2 counties and again pulling in Hillsborough. That being said, in 2010, statistically things are changing. And I'm an educator, and by habit, I always get my audience involved. I love group participation, and I'll keep this real simple, and I'll keep it very much without getting too personal, and I'll just ask a broad question. How many of you here in this room know at least somebody? It may be family, it may be you, it may be a neighbor, or someone in your church, but how many of you know somebody who is affected by diabetes? You can't not raise your hand. You can't not raise your hand. The statistics right now say that by 2050, 1 in 3 of us Americans will have diabetes at some level. Type 1 and type 2 diabetes are on the increase, and gestational diabetes is as well. What everyone has in common, beyond knowing somebody with diabetes, is that that person or people or group that you know with diabetes lacks the understanding of their own disease process. And it's what pulled me into diabetes. I started out as a cardiac nurse on a progressive heart unit, and within 3 years I got pulled into the interest of diabetes because over 30 to 40% of the patients at some level had some abnormal glucose. And when I looked at people living with diabetes for years and asked them, I wanted them to teach me about diabetes because what they taught me in school was about 5 pages long. And those individuals living with diabetes could not answer the most fundamental questions and were at the mercy of their health care to get it right for them. And the challenge of that is that healthcare professionals have way too many things on their plate, and they cannot specialize in the field of diabetes and certainly how to teach patients how to care for themselves and keep themselves out of hospitals. In 2010, we went after a grant to open up our education services to all people regardless of pay source, meaning if they were uninsured or had insurances that did not recognize the pure benefit, which has been documented, that patient education for diabetes self-management does keep people out of hospitals, keeps their monthly health care dollars down, keeps them being readmitted into hospitals. There are insurances who do not recognize this as a benefit that they want to cover. So in 2010, we went after the grant so that anyone uninsured or had insurances that did not cover and recognize the benefit could come through our doors and receive the education at their level. And when I say education, it's a bit of a misnomer because we aren't teachers. We're facilitators to help people find their way with a chronic disease. The thing we know about diabetes is it does not have to complicate your health. But when you do not understand how to navigate your healthcare system, what resources to go after, and how to just take care of yourself on a day-to-day basis and educate the family to show support to people who are dealing with these chronic diseases, they do not have to come in with health complications, and people can live very healthy with diabetes, but most are not. And less than 50% of people take advantage of the education services, and it's not just because they don't understand what the service is, though we market our services very hard in the community. They just don't know that they have the opportunity to come in and get the services. So with that being said, we've also added on a grant about 3 years ago because for a nurse case manager. Our center right now has got 3 grants actively running for almost $200,000. And that grant money gets turned around, and our education grant is 100% funding back to the patient. There are no other costs. That is $1 per dollar per person walking in the door, and they receive services that are completely seamless to anyone else that has a pay source. Now let me tell you just a few minutes about who's taking advantage of this money. And I also want you to see your $50,000 contribution to our global grant funding program, the investment to the dollar you're going to get for $50,000. Diabetes is over $245 billion in medical, direct and indirect costs to our population here in the United States. Florida has almost 8% of its population with diabetes, and Hillsborough, Pinellas, and Pasco County are 8, 9, and 10% population, respectively. I want to give you 3 quick stories, because there's no better way to show you how $50,000 touch lives. I have one person who came in. She requires and must have insulin. She had a pancreatic disease. She's homeless and living on the couch of a dear friend. And that's how she gets by day. She was scared to death when she got into our program, and we met her through Good Samaritan Clinic. And I'll have to say that both Clearwater Free Clinic and Good Samaritan, we see almost 100% of the people walking through their doors because we have no barriers for them. They walk in freely with just a referral. This one woman is in her 40s, and she has struggled with taking insulin every day, 4 shots a day, scared to death and guessing at what she was doing. And quite frankly, I've been doing this for a while, but I am still amazed at how people even stay alive with how they're managing to get through with some very, very strong medication. Well, it was because of our grant and the relationship that we have with Good Samaritan in Pasco County. She was referred into our program. She leapt at the opportunity. She did not know this was available until she got into the healthcare system of the free clinic. And she has completed our program. We continue to support her as needs go, because our case manager does help and stay in touch with people for other needs. Her satisfaction survey that she returned to us as a volunteer survey, basically, she recognized that without that grant funding, she would have been back in the hospital probably within a couple of weeks of entering into Good Sam's care. And it was not because she was not getting the care at Good Sam's. It's because of the demand of understanding what she's supposed to do from a day-to-day. She's getting excellent care through the health clinic, but it's that self-care, those decisions she has to make, and how to troubleshoot her insulin that saved her from going back into the hospital. Another gentleman just came through our program. He is homeless. He is living in a trailer. He would not tell anybody about his situation because he doesn't want to get evicted. Because an elderly gentleman has taken him into his home on his property, but giving him access to live in a trailer that does not have running utility. He uses a refrigerator and a sink in a garage. He could not get into our center because of lack of transportation. We met him through Good Sam's. We met him once. Because of his health condition, he had no transportation, has to ride a bike, get to the bus. He has severe COPD and couldn't ride his bike to get to the bus to get to the clinic. Through our grants and through our case management support, we have now got him with bus passes through Good Sam's. He is accessing the health care through the clinic, getting excellent care. And I met him just last week when he came into our program, which he had to delay for 2 months because of transportation. But because our case manager is a watchdog and she's relentless, she was able to secure some bus passes through Good Sam's. He now has complete access, and the confidence on his face, the confidence of knowing he's got health care to come to and what he's learned to navigate. He doesn't have a refrigerator. What kind of foods can he have? How does he manage his diabetes with medications when he can't monitor his blood sugars? Well, now we have him with a meter. These are things he would not have otherwise. And he has the confidence now to understand how he can navigate his very challenging life. And he now has complete access to his healthcare team. And last but not least, I have a woman who started out at the breast center. Because of her health, she lost her employment because she could not work. She received excellent care through the breast center and hit my radar when I was teaching up at North Bay, and my case manager called me and she said, Could you find during a break, if I can arrange for her husband to show up in the hallway of the hospital, could you meet with him and just maybe give him a meter because they're desperate. They have no insurance. Her diabetes is now starting to escalate because of all the other medication and treatment she's received for other health complications. And that's how our relationship started, through her husband in a hallway of North Bay Hospital. She eventually got well enough to be able to come in one-on-one. She would not have come in, would not have access, except for the education grant. I have the honor and privilege of working with people like this every day. She's doing beautifully. We've been able to help her prevent some things that were coming down her track with a foot infection. We were able to get her medication regulated, got her to her medication resource, communicated with her healthcare team. And now, as she put it, I have the prettiest feet in my county because her foot care was something she never even thought of. And she could have very easily, she has neuropathy, she has loss of sensation in her feet, and that didn't mean anything to her. She didn't know what could happen. She's already lost some body parts to cancer. She shouldn't lose it to diabetes. And she didn't, and I'm pretty sure she never will. So for $50,000, sorry. You saved lives, body parts, souls, and integrity. And I thank you.
Thank you. It is such a privilege to work with such passionate, dedicated people as Cindy and Ellie and Gail and Margie, and I feel very honored to be up here today. I'm going to tell you a little story about myself. I've been a nurse for 40 years, and of those 40 years, 39 have been dedicated to improvement of health and well-being for women and children. And so they hold a very special place in my heart. And today I'm here to talk about a very small grant, only $10,000, and basically the grant is to bring trainers from Boston to our area to initiate the TIMBo program in Florida. Right now it's just basically in the Northeast and in the Boston area. The TIMBo program is important to me because in the late 90s I was on the fast track. Morton Plant Meese had just merged, and I had a very big job at the time, going to 4 hospitals, and I also had surgery that year and was divorced, all in 1997. And you know, I had a wonderful group of people that I worked with, but I was desperate for something more. I just needed to feel better. I had a lot of people depending on me, and that's when I found meditation and yoga. And I started out by watching Lilius on TV at 6:30 every morning, and really turned my life around. And a couple years ago, I got to actually meet her and practice with her up at Kripalu in Lenox, Massachusetts. I stumbled upon the TIMBo program when I was looking for a mind-body program that would be low cost, that could impact a lot of women, because I knew what being connected to my body, it did for me as far as empowering me in my life. I found Yoga Hope, which is a not-for-profit yoga program up in the Northeast that created the TIMBo program, Trauma Informed Mind Body. And what the program does is it will train facilitators who then can go out and produce this program in the community. It's a series of 10 classes that women can take, and the women can have any form of trauma. And in fact, I looked up the definition of trauma, and basically all trauma is significant stress that is extremely intense or occurs over a long period of time. So probably all of us have had some form of trauma in our life. But it probably didn't impede our ability to perform in the community and as a family member, etc. One thing I found when I learned meditation and yoga was that I was a human being that had turned into a human doing, and that I was living my life from here up. I was basically a walking around head, always thinking, but never really connecting to anything else. So you heard Cindy mention her soul and their bodies, and basically we are beings that aren't just our brains and just our heads. We're our hearts, our souls, our feet, our hands, etc. So the program that I'm proposing would be a partnership with White Orchid Yoga. Connie Pappas, some of you might know her, will be hosting the program with us. We will train a minimum of 10 facilitators who then will take this program out into their practice. We'll take it out into the homeless emergency project, which is going to be my project. We'll take it out into drug treatment programs. We'll offer it at the Women's Resource Center here at Morton Plant. Therapists will use it in their practice, but it is a program that is evidence-based. It has been researched as that it is effective. It's part education, part hands-on, part yoga. I don't want to stress the yoga too much because sometimes that's kind of like out there and people are a little bit afraid of it, but it does use yogic principles and the connection between the mind and the body to improve the health and well-being of the participant. Any questions? Yes, Darlene.
Well, it's not a question, just a statement. I've been a nurse too also, for like the 42 years, sorry, Marcia. But she had trauma, stress, and nursing is so stressful. So you listen to these other programs, you have to have a nurse at the bedside. It's got it together too. It just is something else nowadays. And so I encourage you to just think about this. It's a small project. We'd like to grow it. And we just need to do it. Secondly, we've been magnet for a while. Now we're pursuing something called the Pathway to Excellence. It's another national recognition by the American Nurses Credentialing Center. And this one's more about nursing itself, because if we have great nurses, you're going to have great patient quality of care. So I'm going to go for this one.
Thank you, Darlene. One of our primary target groups in the health system will be nurses. Many of our nurses do suffer from post-traumatic stress syndrome or stress disorder or whatever because of the fact that every day they see some of the things that we're just talking about. And Darlene, that's very appropriate, that this will be a way that we can too care for our caregivers. And probably that's what I've done more of in my life than actually providing the hands-on care to the patients. It's actually taking care of the nurses. So thank you. Any other questions? Yes.
Is the training open to other organizations if they wanted to?
Yes.
Free clinic if you wanted to have someone?
Yes. There is a cost to the training. However, if you're a community partner with Morton Plant Meese or Baycare or in one of those areas, there will be a discount to attending the program. This is a not-for-profit organization that provides this. They don't make money off of providing this training, but they do send 2 facilitators to provide the training in this area. And they stay for either 3 to 4 days each time they come. It's a series of 4 modules that we'll be taking. Any other questions? Thank you very much.
Hello, good afternoon. I'm Joyce Hall. Can you all hear me? I speak loud even without the microphone. The volunteer nurse program started at Countryside Meese in 2009 with about 19 to 20 nurses. I was one of the original. We still have 5 original. Right now we have about 17. It's like any job. Some people come in, they go out, they have other things in their lives and whatever. They're at all 4 facilities now, although it started at Countryside. And we tried to implement and help just fill in for the nurse. One of the things one of the nurses out at Countryside asked me, why are you doing this? And it is boring at home. Television is down the tubes. Tired of reading. And if you think about it, I spent half my life in a hospital. Can't work 12 hours a day, but I can work 4 to 6 and help out. And I think most of the nurses feel that way. We've come from a big background. It's amazing when people tell us where they came from. They've come from Europe. They've come from every known facility all throughout the country and from every occupation that nurses do. And I'm an old-time nurse, so when I was a first nurse, if a new thing came along, whatever it was, let the nurse try it. So we tried everything until they'd start training people. And it really helps. The other thing is they said, well, they need us. But if you think about it, like the nurses out at Countryside, I was on an oncology surgical floor. The patient comes into the ER, they're rushed to surgery, they're rushed to their room, they're rushed home. So the nurse doesn't have a lot of time to connect. And that's kind of where we can fill in somewhat, because we can still do, we can't do all the nursing procedures like the nurses because of legalities with the hospital. We're not paid and so on and so forth. But we can do things like spending extra time with them, calling their families. I mean, just doing all the extra thing, and we can take the time that the other nurses can't. Not that they couldn't do these jobs. They can talk to the patients and they can do things. And now that we're in like the emergency room, the rehab, the outpatient, all the floors, NICU, OB, and we've done all kinds of different things. And we do go out in the community. I was involved with Judy, who is our coordinator, to set up a little table display that we take to the community, show about the volunteer nurses, and try to get other nurses to come in. But while we're out there, we're also promoting the hospital. And although I'm a volunteer, I'd like to tell you just a couple stories. I worked in day surgery here when I first moved to Florida. And we had an orderly that came in. He was probably 62 or 3. And he worked most of the day, maybe 6 hours. And he'd retired as the vice president of a company. We have a tremendous amount of people that live here and come here that could really help the hospital, and they do. The volunteer program is really great. Whatever. I was telling someone, I think Sarah, that I'd worked at a children's hospital in nuclear medicine. I have a wide variety of background. And we needed space. We were in this little corner and the volunteers had all this room. So I asked the doctor, can't we get one of those rooms? And he said, oh my God, don't touch the volunteers. They run this place. So we do need volunteers, and we're trying our best to get the nurses to come in. And this past year, since January the 1st, the volunteer nurses, I think we have 17 right now active, was 1,100 hours that we gave. Usually we work like 4 hours or whatever. I have a couple stories. I don't want to keep you after lunchtime. When I worked at Countryside, but I live close here, so I moved to the Morton Plant facility. This patient was about a 55-year-old man who works as a scientist, and he knew all about the brain, and he was diagnosed with a severe death penalty, if you would, a brain tumor. And he wouldn't smile, he wouldn't do anything. So his nurse asked me to spend time with him. And I would go in and talk to him, but he wasn't very receptive. His mother was, and his wife was. They were both with him. And the clowns came on board, which is another volunteer thing. And I asked him if it would be okay if they'd come in, and he said no, but his wife said, oh, please, I need a laugh. So I went out and talked to the clowns and explained to them, and they came in. And after they left, he smiled, and his wife said, oh, thank God, thanks for the clowns, and thanks for volunteers. And there's just a lot of stories like that, and we try to fill in and do whatever. We work with the nurses taking care of the patient. If she says do this or do that or spend extra time, we try to. We do some clinical things. We can remove IVs, take out catheters. If the patient's going home and needs a little more time and educating what they need to do, we can do that kind of thing. And it's really been a joy for me, and I've gotten as much out of it as the patients that I've tried to help, I'm sure. Any other questions or anything while I'm here? I know you guys have had a, sure.
I just want clarity. The $30,000 you're asking for, is that to pay for licenses while you're volunteering?
Yes, what they do is they give us continuing education, which is cost maybe $60 a year through the CE Direct program that Morton Plant has, and they'll reimburse us for renewing our license, which we have to do every 2 years, which is like $93. Our coordinator, our nurse coordinator works, I think, 12 hours a week. It pays her salary and some of the supplies that we need when we go out for our brochures and that kind of thing. And Judy Gamberly, who is the coordinator, would know more along that line than I do. They also give us money if we want to eat in the lunchroom. We get the employee discount and that kind of thing. It's mainly, I think, to help us get out in the community and spread the word. And we do for nurses, but I think we also do it for volunteering and for the hospital, although I think I belong to a women's group and most of the people know that Morton Plant's the best there is. So, yes.
Yes, I just think this is a wonderful, innovative program. Nurses in general are people that have a wonderful attitude and they like to connect with people.
Yes.
The pace of life is so fast right now that the patient is lying there. Yes, they may have visitors from family and friends, but there's a lot of in-between time. And this program with this wonderful group of people fills in that huge touch. So it's an excellent program.
It really does. One other story, when I was at Countryside, there was a young woman with a very severe flu, and she was like 6 to 8 weeks pregnant, and her nurse asked me to go in, and I would go in and every 15, 20 minutes say, hi, how you doing, what can I do? Her husband also had the flu, and they had just moved here. She had no family, nothing. She had no job. He was supposed to have one. And I spent my 4 hours going in periodically and trying to cheer her up, talk about our area and that type of thing. But I also told the nurse to make sure that the next volunteer nurse that came in the afternoon would do the same thing and follow through. And this lady sent back a very, very nice thank you card that we really helped her through. Her husband couldn't visit, but eventually he did. Any other questions?